The jugular venous pressure waveform is one of the most underutilized yet powerful tools at the bedside. In the next few minutes, we will decode every wave, every descent, and every pathological clue, with high-yield points for NEET PG and INICET. The normal JVP waveform is a story of pressure and flow in the right atrium, written in 5 distinct events. First, the A wave. This is right atrial contraction at end diastole, pushing blood into the right ventricle. Next, the C wave, a small bump caused by the tricuspid valve bulging into the right atrium as the ventricle begins to contract. Then comes the X descent, atrial relaxation combined with the downward tug of the tricuspid ring during systole, creating a fall in pressure. After that, the V wave, a gradual rise as venous blood fills the right atrium against a closed tricuspid valve. Finally, the Y descent, a sharp drop when the tricuspid valve opens and the right atrium empties into the ventricle. Master this sequence, and you have the foundation for every clinical diagnosis that follows. When the A wave changes, it is telling you about resistance to right atrial emptying. A large A wave appears when the right atrium contracts against a stiff or obstructed right ventricle. Think tricuspid stenosis, a mechanical barrier. Think pulmonary hypertension, a stiff right ventricle that resists filling. Or Eisenmenger complex, where shunt reversal floods the right side with high pressure. On the flip side, an absent A wave is just as diagnostic. In atrial fibrillation, there is no coordinated atrial contraction, so the A wave vanishes completely. Spotting this on JVP examination is a classic bedside skill. Two conditions with very different JVP signatures are constrictive pericarditis and cardiac tamponade. In constrictive pericarditis, the rigid pericardium forces rapid early diastolic filling. This produces a prominent, rapid Y descent, known as Friedreich's sign. The JVP may actually rise with inspiration, which is Kussmaul's sign. In contrast, cardiac tamponade is all about impaired ventricular filling under pressure. The X descent remains prominent because atrial relaxation is preserved, but the Y descent is blunted or absent. The pericardial fluid prevents the ventricle from expanding to receive blood. This distinction is a perennial favorite in NEET PG and INICET. Now, imagine the right atrium contracting at the exact moment the tricuspid valve is slammed shut. The result is a Cannon A wave, a super large, often visible pulsation in the neck. The mechanism is AV dissociation. The atrium and ventricle are beating independently, and whenever they fire together, blood has nowhere to go but backward into the jugular vein. In ventricular tachycardia with retrograde conduction, you see regular Cannon waves. In complete heart block, they are irregular, appearing only when a P wave happens to coincide with a QRS complex. And in supraventricular tachycardia, rapid regular pulsations produce the so-called frog sign. Tricuspid regurgitation rewrites the JVP waveform in 3 dramatic ways. First, the X descent disappears, because regurgitant flow from the right ventricle back into the right atrium cancels the normal downward pressure drop. Second, the C and V waves fuse into a single giant CV wave. Systolic filling of the atrium is massively augmented by the backflow. Third, when the tricuspid valve finally does open, the high-pressure right atrium empties rapidly, producing a steep Y descent. This triad, absent X, giant CV wave, steep Y, is pathognomonic for severe tricuspid regurgitation. Beyond the waveform itself, 2 bedside maneuvers are essential. First, Kussmaul's sign, a paradoxical rise in JVP during inspiration. Normally, JVP falls on inspiration as intrathoracic pressure drops, but in constrictive pericarditis, restrictive cardiomyopathy, severe tricuspid regurgitation, and right ventricular infarction, the JVP rises instead. Second, the hepatojugular reflux. Applying sustained pressure over the liver produces a sustained rise in JVP. This confirms elevated right atrial pressure and impaired right ventricular compliance. Both signs are high-yield clinical pearls. Let's apply this to exam questions. Question 1. Cannon A waves are typically seen in which condition? The answer is complete heart block, because AV dissociation allows the atrium to contract against a closed tricuspid valve. Question 2. A prominent V wave in the JVP is most characteristic of which lesion? The answer is tricuspid regurgitation. Systolic backflow into the right atrium produces the giant V or CV wave. Question 3. In cardiac tamponade, Which JVP finding is expected? The answer is a prominent X descent with a blunted Y descent, because pericardial constriction prevents rapid ventricular filling. Question 4. The Y descent is reduced in which condition? The answer is tricuspid stenosis. The stenotic valve obstructs passive emptying of the right atrium. These patterns are high yield and repeat across exams. Here are more exam-ready questions. Question 1. Which JVP finding is characteristic of constrictive pericarditis? The answer is a prominent Y descent, Friedreich's sign, due to rapid early diastolic filling. Question 2. Kussmaul's sign is seen in all of the following except. Remember, it is seen in constrictive pericarditis, restrictive cardiomyopathy, severe TR, and RV infarction, but not in cardiac tamponade. Question 3. A sustained rise in JVP on liver compression indicates. The answer is hepatojugular reflux, signifying right heart failure or elevated right atrial pressure. These questions test whether you understand the physiology, not just the memorized facts. To summarize, the JVP waveform is a real-time hemodynamic monitor. The A wave speaks of atrial contraction and its obstacles. The Cannon wave screams AV dissociation. The giant CV wave whispers tricuspid regurgitation. Learn to read these patterns, and the neck becomes your window to the right heart.